Welcome, everyone, to our fourth RxTalks webinar, brought to you by Omeda Rx. We're happy to see some returning people and some new people in today's audience. Today we have our resident speakers, our own Dr. Shirley Reitz and Rich Adams, and a special guest speaker, Dr. Steve Lamb. I'll tell you more about Dr. Lamb in a moment. My name is Dana Madison, and I'll be one of your moderators, joined by Allison Donahue. We'll be keeping things running behind the scenes. Today I'll go over some housekeeping items, introduce our speakers, then pass it over to them to review our topic, and we'll wrap up with questions and answers toward the end. Out of respect for our presenters, everyone is automatically muted. We will capture questions throughout the presentation using the dialog box. Simply submit your questions and we will send them to the presenters to read and answer later in the presentation. Today's session will be recorded. As mentioned, our speakers today are Dr. Shirley Reitz, Dr. Steve Lamb, and Rich Adams. Dr. Reitz currently serves as a clinical pharmacist client manager for Omeda Rx, where she has strategic responsibility for developing, communicating, and reporting the outcomes of clinical initiatives impacting both cost and quality of care to members and clients. Before joining Omeda Rx, Dr. Reitz was Director of Pharmacy Clinical Services at a large health cooperative, where she was responsible for designing and implementing medication use management initiatives. Rich Adams currently serves as a Director of Product and Business Development at Omeda Rx, where he oversees sales, account management, and product development. Before coming to Omeda Rx, Rich held various sales leadership positions at industry-leading healthcare companies. Rich's career work focuses on helping organizations navigate the new health economy. Dr. Lamb currently serves as a clinical pharmacist client manager for Omeda Rx, where he has strategic responsibility for developing, communicating, and reporting the outcomes of clinical initiatives impacting both cost and quality of care to members and clients. One of his areas of expertise is monitoring specialty trend. Prior to joining Omeda Rx, Dr. Lamb was the resident pharmacist at Moda Health, where he was exposed to a variety of roles, including formulary management, prior authorization, government programs, and specialty pharmacy. With that, I'm going to hand it off to Rich Adams. Rich, take it away.
Dana and Allison, thank you so much. It's great to be back talking about pharmacy again. And Dr. Reitz, it's nice to see you again. Thank you for joining us.
Hi, Rich. Good to be here.
And Dr. Lamb, welcome. Thank you. Today we're talking about specialty. We are talking about market forces driving specialty drug growth. Then we're talking about integrated and personal specialty care management, the unique components that are related to caring for patients when they have been prescribed a specialty medicine. And then we have our traditional questions and answers. We'll also end with questions that you should or could be asking your PBM as you're evaluating different specialty pharmacy solutions. So here we go. As a little bit of background, we have been talking about over the last 4 sessions the increase in pharmacy spending, prescription spending within the United States. And as a refresher, we've talked about between 2006 and 2012 a relatively nominal inflation increase in spend, somewhere around 1.5% to almost 3% per year. But then suddenly in 2013 and 2014, we saw a dramatic increase in spend. And CMS actuaries forecast that to increase at a rate of about 6.9% compound annual growth rate through 2022. Excuse me. And there's significant drivers, complicating factors that are causing that increase in spend. And we've talked about them. We've talked about brand drug price increases, pharmaceutical manufacturers increasing the prices of medicines, drugs, for new brand releases and products that have been in the market for 24 months. We've talked about new types of drugs or an increase in the types of drugs that are on the medical benefit, the below the line that we talked about, those infused medicines. We've talked about the FDA approval rates in 2008 when they introduced new approval criteria, which had the effect of accelerating the approval rates of medicines into the marketplace. And then finally, we also talked about pharmaceutical advertising and the increase in the amount of investments that pharmaceutical organizations are making to help medicines reach their peak performance or their peak profile from a financial standpoint as quickly as possible. And today, we're talking about specialty drugs. We've also talked about solutions that are in the marketplace. We started off with the most important from our perspective, which is evidence-based medicine, determining which medicines are good and which medicines are better, and the importance of being early, accurate, and personal. We talked about integrated drug utilization management, meaning the ability to see drugs that are on the pharmacy benefit and drugs that are on the medical benefit, and then helping patients get to the right medicine at the right time through the right provider and in the right amount. Today, we're talking about specialty drugs and its personal approach from a therapeutic journey standpoint. And then the last two, we'll talk about site of care management and innovative consumer engagement programs in November and December. So that was a quick background. So let's jump right in, and let's start with Dr. Reitz. Let's start with what are specialty drugs and what makes them different? What are some key features that are associated with them? And one thing I do know is that there is no firm definition of a specialty medicine. But Dr. Reitz, I know you're going to help us understand what they really are.
Well, thanks, Rich. You're right. There is no firm definition, universally accepted definition of what a specialty drug is. But what we do know is that there are some specific characteristics or features that help define a specialty drug that is generally used by healthcare providers. First of all, we know that they are generally prescribed by a specialist. So you think of disease states such as rheumatoid arthritis, where you have a specialist like a rheumatologist that's going to be prescribing those drugs, or oncology, where you've got an oncologist going to be prescribing those drugs. So often specialty provider is involved in the care of these patients. Many of the drugs are injectable drugs, although I would say that over time that's changing. In the recent past, almost all specialty drugs were injectable. Now, as new drugs are coming out, we're starting to see some of them move over into the oral or other, or not just infusion, but sub-Q as well. So we're starting to see more drugs come out from the FDA that are going to be on the pharmacy benefit, not just the medical benefit side of the house, and can be administered orally. Now, the issue there, just to keep in the back of your mind, is just because they're given orally doesn't mean that they're less complex or less difficult for the patient to take, or that there is potentially fewer side effects that you have to be able to manage in those patients. Some of these drugs require special handling. So the thing that comes to mind there for me is really around cold chain technology and management of drugs because of their nature of the medication itself. They do need to be either frozen or they need to be refrigerated, and you need to maintain that over time throughout its distribution, throughout its whole chain of distribution. You need to keep a consistent temperature, otherwise you potentially lose efficacy for those drugs. And then many of these drugs, well, most of them really require a high-touch patient management. So these are complex meds. They require patients to really understand the disease state, to become adherent, to understand why it's important to be adherent, and they, because of the side effects that need to be managed, you would really want to keep very close touch with these patients to help them manage their therapy. So some of the conditions that we've talked about, or that you see here, we've talked about already some of the inflammatory conditions in oncology, but also other conditions that are commonly seen that specialty drugs are used to treat include hepatitis C and multiple sclerosis. An interesting category is one such as orphan diseases. Orphan diseases are diseases that impact less than about 200,000 people in the United States. That's what classifies as an orphan disease. Very often there's not a drug that's available to treat that disease, or it's very difficult to treat that disease. And there's lots of research that's going on in those areas right now. Recent example of one that just was approved 2 days ago is one for Duchenne muscular dystrophy, a drug that treats a certain genetic mutation in patients with this DMD, with this disease state, and can cost about $300,000 a year to use this drug.
So they're different, very, very different. Sounds like lots of care management, lots of providers that need to be involved in it,
right.
Lots of high touch maybe even a painful experience if it has to be an injectable medicine, is there's a word that's used in the industry now called biosimilars. Now, are biosimilars specialty medicines, or are they a completely separate class that we need to talk about also?
Yeah, biosimilars, similar to their reference product or the original, the brand, if you want to call it, drug that they come from, are also considered specialty drugs. So just like the reference product, just like the original product on the market, we would manage those in very much the same way. They continue to have the same potential adverse events as the brand name product. They also are very costly. What we've actually seen for the one product that's actually marketed and available commercially in the United States, it's about 15% off of the reference product. So not significantly less expensive than the brand name product.
So a specialty medicine for a specific disease, an orphan disease, for example, that biosimilar would be for that same orphan disease.
Yes.
Okay, got it. So they're kind of in the same bucket.
Mm-hmm. Yep.
Well, we certainly would be remiss about talking about specialty medicines if we didn't talk about the financial component of it, the cost. What can you share with us in terms of the growth of specialty medicines over time from a cost standpoint, and then how do they compare to traditional medicines from a distribution of total pharmacy spend for a typical client or for our book of business?
Yeah. Well, in 2015 in the U.S., we spent probably over about $450 billion, that's with a B, billion dollars on prescription drugs. So the cost is enormous. The total cost that we're spending is very high. If you look at this graphic, you can see that back in around 2000, less than 2% of total cost of drugs was in the specialty marketplace. And as you move forward to currently, we're sitting at about 30% right now. And as we move forward even further into 2020, the projections are that 50% of our total drug costs will be in specialty drugs. Now, there's a couple reasons for that, a couple of reasons why we see this really huge growth in drug costs, but also shift to specialty. One is that drugs just continue to increase in price. Brand name products that are already on the marketplace, we've seen that with Humira, we've seen that with Enbrel. Internally, in the last 2 years, we've seen their costs increase over 80%, just within the last 2 to 3 years. So that growth in current medication prices continues to rise. In addition, as we look at new drugs that are coming on the marketplace, there are more and more drugs that are coming out that are on the specialty side. In other words, they're meeting those criteria that we talked about earlier for being a specialty drug, requiring special handling, special management by providers and by pharmacists and by the patients themselves.
What I hear you saying is the cost is not going away at all from a specialty drug standpoint. It will continue to grow, and it'll eclipse the traditional medicine side of it and have significant impact in terms of overall spending for society and then also for employers.
And the other thing that I would add there, Rich, is that traditional utilization management strategies that we've used for years to manage our costs and help employer groups and others really manage their costs, we need to do that with these drugs, but you need something beyond that. That's not going to be enough for the specialty drug marketplace as we see it start to evolve in the near future. So we have to think beyond what our traditional strategies are and start thinking about new ways to manage these medications.
Dr. Reitz, you mentioned the pipeline, and I'm wondering how does a research and development organization, a pharmaceutical manufacturer, how do they go about determining where to invest, where to develop product, and what disease categories or therapeutic areas to focus on? How does that come about? Is it random? Is it a very thoughtful process, or what drives it?
Well, it's never random in the pharmaceutical industry. They're a business, and they are looking for ways to get their return on investment that they put in. So it's very thoughtful, and it's good that it's thoughtful. Obviously, they want to look to see if there are disease states that need a therapy to be developed to manage them. So they're really looking to see what are the opportunities out there, where are there disease states where there's not good therapies, or even if there's therapies, can they improve on the therapies that are there to increase either the efficacy or reduce the side effects for patients that are receiving these medications. So there's a very good reason for them to go after these medications and to do the research and develop the infrastructure to build these, to market these medications. It's also important to understand that they are a business, right? And so they're going to look for medications where there's a great opportunity for them to get their return on investment. So these drugs that are part of an orphan drug category where there's not going to be a lot of competition out there, they're more likely to go after those types of indications because they do want to get their return on investment.
It's interesting. So I immediately thought of the Vice President's initiative, the Moonshot, to cure cancer. And I would imagine that that would have an impact on pharmaceutical manufacturers and their desire or their business decision to move into investing in products that would help solve cancer.
Yeah, and actually, so where there's monies available to pull, grant monies, that kind of stuff, there's going to be a great interest in going after that. I actually just saw on the news, I think today or yesterday, that the inventor of Facebook, right, Mark Zuckerberg, and his wife have put in, I can't remember the number, but it was a huge amount of money that they are now putting into the community to try to reduce a disease in the United States, well, worldwide. So now that amount of dollars is going to be available, you're going to see a lot of researchers go after that kind of grant money to do work that's really important work.
And so that's reflected in the pipeline that we're seeing here, and we see the number of products, and so we see that cancer, there are about 1,800 drugs that are in the pipeline under development. That's one of the larger ones. Neurological, I believe that would be multiple sclerosis or Alzheimer's disease, right? And then infectious diseases, that category would be.
It's often things like hepatitis C and antibiotic type of indication of drugs.
Okay, that's great. As you look at the pipeline in terms of dollars spent, does it also reflect the investments that are being made by pharmaceutical manufacturers, those medicines that are being approved, and then what's actually being spent within the United States?
Yeah, if you look at this graphic here, you could see we actually compare 2013 total cost for the top 15 specialty drug classes versus 2014. And you can see it grew from $14.6 billion to $18.4 billion. That's a huge increase in dollars spent in 15 specialty areas over 1 year. What's important to note in this graphic too is that about 2/3 in each of those years is focused on 3 areas: cancer, inflammatory conditions, and multiple sclerosis. The one major difference that you see between those 2 years is that in 2014 we start seeing hepatitis showing up as a major player in the top categories for specialty spend. And again, that's because those drugs came out at the end, a couple of drugs for the treatment of hepatitis C came out at the end of 2013. So we start seeing those costs in our 2014 year.
As you look forward a little bit, maybe into 2016, 17, 18, maybe into 2020, do you see this pie chart on the right changing dramatically, or do you see it staying primarily focused on oncology products, the cancer products, and then inflammatory conditions as well?
Yeah, those are going to continue to be the top 3 across, even with time, as we look forward to 2018, 2020. I think what you are going to see is you're going to see more of the hepatitis because obviously there really was a backlog of patients that were waiting to be treated with these medications. We're going to see that wedge of the pie is going to increase if we looked at it today. We looked at 2016 data.
Cost globally is significant. What about costs from the patient standpoint? What's the impact there?
Well, this graphic, I think, really points out the difference. If you look at, this is a patient financial impact across the United States that was developed and defined by the Blues Association. And what they did is they kind of broke it out by geographic areas, which is kind of interesting to look at, because if you look at particularly the 2013 numbers, those red numbers across the top of the page there, you can see there's a huge variation between what we're paying in the Northwest versus what's being paid in the South Central area down in Texas versus what's being paid in the Northeast. So, you know, what does that relate to? Why is there such a huge variation in costs for patients for specialty in those areas? Well, I mean, you look at what we know, and we've talked about in previous webinars, is there's a very large variation in prescribing practices across the country, primarily because providers use have different education or different ideas of how to treat disease states. One of the things that we've tried to do, and very consciously, is to use our evidence-based medicine to really, what would be, I would say, normalize that process, to really make sure that we're using the right drug in the right patient moving forward. You can also see that as you look at 2014 data, there was a pretty big increase between 2013 to 2014, on the average of about 26%. But if you look at those, it ranged all the way from a low of about 10% in some districts all the way up to an increase in about 42% in some areas. So that huge variation in cost really have patients concerned about, how am I going to pay for this? What are the issues? How do I make sure I'm getting the best value for my medication?
So we've talked about a full pipeline, lots of medicines, specialty medicines that are there. They're costly, they're expensive, they're complicated. Sometimes you've talked about involving many practitioners, many providers. You've talked about it being stressful on patients, the unique administration of the medicines. They feel very, very different. They feel different than me going to the local pharmacy, standing in line, getting my prescription filled, going home and taking it for 10 days and calling my primary care doctor if I don't get better. That is certainly one experience that I'm very familiar with growing up, but this feels completely different from a care standpoint. And so what from your perspective, from a clinical perspective, what do you see as necessary elements of a successful specialty management program?
Well, I think we pointed out very clearly on this graphic that you see here. These medications require an integrated approach, a holistic approach, if you will, to the patient. It's so important that the caretaker is able to look at the entire patient and see what's going on for that patient to help manage their care. It's important to note that about 80%, over 80% of these patients actually have other disease states, chronic disease states that they're managing, along with now this new specialty, this new disease where they are requiring a specialty drug to manage it. So you can't just manage it in isolation. You have to take care of the entire patient, and that includes things like care coordination, making sure they're getting the care that they need, where that's happening, making sure they're getting to their appointments, helping them with their co-pays and co-insurance if necessary, so that financial assistance, because these are very costly drugs. So ability to help them with that. Some of the behavioral type of things, making sure these patients understand the importance of adherence to their medication and understand what their disease state is, connecting them potentially with other patients with the same or similar disease that can help them understand how they cope day to day with the disease state.
From a clinical perspective, Dr. Reitz, what happens if this integrated approach doesn't happen? Do clinical outcomes go down? Do people stay sick? Are there significant cost implications? What occurs? What goes on?
Well, you can go out and get a great discount on specialty drugs somewhere, but if you're not managing all these other things, you're not getting the value that you need for these medications, and you're not helping patients get better by keeping them adherent to their medications, managing their side effects, helping them understand the disease state. So you get bad outcomes, which then drive costs even higher because they, first of all, are wasting drugs. They're not using it appropriately. And secondly, they're moving on to either more expensive drugs or they end up hospitalized because of their disease state. So you can drive higher costs by not paying attention to these things.
Yeah, from our previous discussions, I remember you talking about the cost of non-adherence.
Yeah.
It's in the billions of dollars, and I would imagine that that's a particularly acute problem here, or challenge that we face, helping patients stay adherent to medicine.
And the risk of non-adherence with these medications is high because of their cost. And that's why it's important to have a really holistic approach to these patients and helping them manage things like the cost and how they're going to be able to pay for these medications.
Good discussion. Well, broad discussion, right? Great overview.
Yeah.
Lots of dynamics going on in the marketplace right now that are having an impact, a unique care model that needs to be employed, implications for employers, consultants, brokers, certainly health plans as we try to tackle this problem. Let's switch now and drive into the detail, talk with Dr. Lamb a little bit more about what are the foundational pieces of clinical medicine that need to apply to help us manage specialty medicines, and then what can we do in addition to that? Dr. Lamb, what do we have to absolutely have in place as a foundation?
Thanks, Rich. So what we have to have is how we typically manage the traditional drugs. So for traditional drugs, we have drugs to treat diabetes, mellitus, high blood pressure, etc. So we've talked in previous webinars about how do we kind of manage these types of patients, and that really outlines the foundation. And really the foundation is it dials back down to evidence-based medicine, right? So when we look at our benefit design, our formulary design, and our utilization management criteria, which is our prior authorization, it's drilled back down to evidence-based medicine and how we can use that as a foundation to build upon. What we are missing for the most part in specialty drugs is that care management piece, and that's where specialty pharmacy really comes in. When Dr. Reitz was mentioning, the holistic approach, how do we get to the patient to make sure that they're taking the drug appropriately, managing their side effects appropriately, and coordinating, with their physicians appropriately to help them or notify them that, this therapy might not be working for the patient. That's the care piece that we are missing today.
So I guess what I hear you saying is we've got to absolutely have a very solid and firm foundation in traditional utilization management components. The contracting, right? You have a great relationship with the supplier that can get you really very solid discounts on medicines. You have to have a firm foundation in evidence-based medicine to develop a formulary. You have to have innovative benefit designs to help members and patients understand where they need to go, what's a preferred medicine, what's a non-preferred medicine. And then on top of that, you need to have integrated utilization management, holistic, looking at all sides of the benefit, whether it be the pharmacy benefit or the medical benefit. Sounds like those are table stakes.
Correct. And like I mentioned before, once you kind of have the foundation developed, the next thing we need to think about is, well, what does the patient need? How can we support the patient so that they become successful?
So let's talk about that a little bit more. When you say care management, what are the elements of care management that are different or more enabled when you talk about integrated management for specialty?
The care management piece is really the hand-holding that comes in to help the patient be adherent to their medications. If we looked at this diagram right here, from a traditional standpoint, let's say you were a patient who got the medication from a retail pharmacy, you might appreciate a 1% savings there, whereas if you had an integrated system where you have your benefit design, your formulary management, and then you're able to transfer that patient over to a specialty pharmacy, you're able to appreciate an additional 11%. And where that really breaks down is, the specialty pharmacy is able to reinforce dosing management, reduce waste management. So let's say we have an oncology drug, right, which has been shown to have a lot of dropouts in clinical trials. What we want to do is implement something such as split fill, where you can get the medication for 2 weeks just to make sure the patient can try it, make sure that it works for them, and they're not having any major side effects that would want them to get off of the medication. And it protects the employer groups as well, where they're not paying for the full price of the drugs for a whole 30 days. You're just paying for the 2 week supply. for there. And then what other things specialty pharmacy can do is really optimize, again, and reinforce the preferred drug strategy, so our criteria and our formulary benefit. They're able to speak with the patient and let them know why this drug is important for them to be on. Because what happens if they're not adhering to the medication, then they're going to graduate to another therapy that might be more costly, that might not be preferred on our benefit today.
So I'm remembering what Dr. Wright said earlier. You can go out and you can get a good discount on a specialty drug pretty much anywhere, right? But if you don't have an integrated care model, then you're not going to really have a significant impact on overall total medical costs, because you're going to miss things like dosing management, or you're going to miss things like waste management, or integration of the existing with new specialty utilization management as well. What does it look like from the patient's standpoint as they experience an engagement of this new specialty medicine? What does it feel like? What can they expect, or what would you consider a best-in-class program that would envelop a patient and a member in this new experience?
That's a very good question. So let's take, for example, multiple sclerosis. Let's imagine that you are a patient that just recently got diagnosed with multiple sclerosis. You get a prescription from your provider, and it's for a medication such as Avonex. Avonex is a self-injectable medication. You might think to yourself, well, where do I even begin at this point? What specialty pharmacy does, it closes that loop in care. Because if you think about traditional drugs, you would go into the pharmacy, such as a Rite Aid or a Bartell, you pick it up, you take the medication, and if something happens, then you report that to your doctor. Here, specialty drugs are different, right? Because it's going to require special monitoring for the most case. It's going to require you to learn how to, or at least understand how to inject the medications if it's injectable, and how to deal with the side effects of the medications. So if we take, for example, if you are a new patient who has a prescription for Avonex, when you go to get your first fill at a retail pharmacy, for the most part, the best-in-class, specialty pharmacies will allow that first fill to happen within the retail setting, just so that we can coordinate that care and make that transition smooth for the patient. Certain, specialty pharmacies won't allow that, or the plan benefit won't allow that, and it will cause the point of sale to actually have a rejection and ask the patient to have the prescription routed back over to the specialty pharmacy. So there are some differences depending on which specialty pharmacy you go with and which health plan benefit you go with as well. Once the patient is transferred over to the specialty pharmacy, there is an onboarding process that typically happens. So what that looks like is they have a patient care coordinator who's on the phone with the patient, who takes their health insurance information, gets their side effects that they've had maybe to other medications, or they also run the bill. They also run the bill to make sure that the claim will actually pay for the patient, so they don't have to worry about any of that stuff. They will then, allow the opportunity for the patient to be warm transferred over to a clinical pharmacist or a nurse to really talk about their conditions or answer any questions that they might have that they weren't able to get from the provider's office. So what that looks like is the clinical pharmacists within these specialty pharmacies are highly trained. They have a very, very good understanding of the disease state, as well as the medications that are used to treat the disease state. And they're able to speak very highly and intelligently to these patients about what they can be expecting. They can also talk about some of the lifestyle components that come with it. So if you are dealing with the side effects to the medications or just the disease itself, how do you kind of manage this? If you're having muscle aches, what can you do with these muscle aches? Can you use a cold pack, et cetera? So certain things that you might not be able to get if you were just to get the drugs filled from a traditional pharmacy. Other things that a specialty pharmacy can do is really coordinate that financial component, as Dr. Reitz mentioned before. So we know that these drugs are very expensive, but one thing that can help financially relieve that for the patient is things called copay assistance cards. So with the specialty pharmacy, they can coordinate that with the patient, whereas if you were getting medication through a traditional pharmacy, the responsibility would lay more on the patient's side. So here in the specialty pharmacy, they coordinate everything for them to really lower that copay for them so that they can access the medications and so they can continue to take it because it's accessible for them. So you also might be wondering, well, if I'm taking an injectable medication, how am I going to get that training? And here at Omeda Rx, one thing that we really advocate for is increasing access to a clinical pharmacist. So as Dr. Reitz mentioned before, a lot of these drugs, once they're packaged in that cold chain technology and they're shipped to the patient's door, one option that they do have is on the onboarding processes, they can schedule an appointment to speak with a pharmacist once that package is arrived. One thing that they can do is log online or on their phone, and have a video chat or video conference with the pharmacist, or go through the medications with them over the phone, and the pharmacist can walk through with them step by step, how to unpackage the medication, how to load the medication, how to inject the medication, and what to do if you have injection site pain. Do you use cold packs? Do you use things like NSAIDs, etc.?
Let me ask you a clarifying question. So this all feels like it's very focused on helping, certainly high touch, but helping people stay on, one, making sure that the medicine works for them, and then helping them stay on their medicines as well, which is important. We've talked about earlier the importance of adherence and the cost of non-adherence. How does provider coordination work? To Dr. Reitz's point, lots of comorbidities, lots of different conditions that folks are wrestling with, and this is just one of them. Is there a special and unique way that the best-in-class specialty pharmacists can communicate more broadly and help coordinate all the different providers and care managers that are associated with this condition?
Absolutely. So the benefit of having this as a high-touch model and having patients enroll in these clinical programs to work with the pharmacist is they're able to relay to the pharmacist immediately if there are concerns such as, I'm dealing with this side effect, I don't know what to do with it, or if they have multiple sclerosis and they think, they might be relapsing at that point. The benefit of this coordinated model is the pharmacist or the specialty pharmacy can relay that information to the provider, keep them within the loop of what's going on with the patient's treatment, and flag that for them. So if the provider knows that this medication is not working for the patient, or they're just not able to tolerate it because of the side effects, the provider can then reach out to the patients themselves, schedule an appointment, and work through with them again to see which direction do we want to take, what is the most appropriate next direction.
Are providers open and receptive to this?
They absolutely love it. Providers love to know what's going on with the patient's therapy, and a lot of times they're not able to, from an operational standpoint or administrative standpoint, to keep in contact with the patient on a regular basis, and specialty pharmacists are able to do that for them. And so they love that service. They love to be able to cue in if something happens, so that they can, do what they do best, which is take care of the patient.
So we've talked about the market itself as a whole, what's going on there. Now we've talked about the delivery model, and we've talked about the importance of being integrated, connecting all the different pieces, visibility onto the pharmacy benefit, the medical benefit, integration of traditional utilization management with specialty utilization management, the importance of being personalized. This is a very, very personalized approach. It's not broad brush at all. It's very specific to the individual. What do you both see, Dr. Reitz and Dr. Lamb? What do you see as the next step, or in the near or even longer-term future for specialty medicines? Are there new innovations that will be coming out? Will it be an increased or a decreased focus on rare conditions and rare disease? Will we go even more precise in terms of individualized care, or increases in efficacy of medicines? What can you help us kind of see as the coming future over the next 3 to 5 years?
Yeah, and I'll let Dr. Lamb speak to this as well, but I think we will see definitely an increased focus on some of these rare diseases and orphan diseases that haven't gotten the focus or the research dollars in the past. There's a great need to provide some care for those patients, or some answers for those patients, so I think we're going to start seeing that more and more. I think also, you talked about the individualized medicine. Dr. Lamb talked a little bit about that from a patient perspective, and how we are going to continue to improve our ability to take care of that patient with their specific issues. But I think also, if you step back from that, you think about some of the research that's going on right now around the genetic impact of diseases, and how new drugs are coming out that's going to impact you as an individual based on your specific genetic characteristics, right? And so I think we're going to start seeing that, and we're going to start seeing medications that are really geared towards how do I manage your disease state given what's going on in your body?
For me, for Rich Adams.
For Rich
very
Adams,
specific
for
condition.
Dr. Lamb, for whomever, for Shirley Reitz, how would I use that drug differently in me versus you versus Dr. Lamb? And that's going to be dependent on, what type of enzyme systems you have. There's all kinds of things that impact that. And so I think being able to manipulate drug therapy for you to get the best effect, the optimal effect that you can out of those drugs is going to be something that we're going to see in the future. Maybe not 2 years from now, but certainly in the next 5 to 10 years, we're going to see more and more of that.
Well, I hope they're all tablets because I hate needles. Right.
I hope so too.
Dr. Lamb, from your perspective, what do you see as innovations and evolutions?
That innovation, point that you just mentioned with, the tablets is actually something we're already currently seeing within the pipeline. So if we take inflammatory conditions, for example, drugs typically used to treat rheumatoid arthritis, osteoarthritis, etc., typically have been self-injectable drugs, intramuscular, subcutaneous, or even IV infused. But what we're seeing in the pipeline now is innovations in the way that we deliver the medication. So there's more oral therapies that are being developed now. And the reason behind that is because most patients don't like injecting drugs, and drug manufacturers know that. So by creating drug therapies that are more easily administered, it increases the access to these patients who really need the drugs. Other things that we also see right now are more and more of these drugs that are being approved, and in the future as well, is they have a better efficacy profile, meaning they're more clinically effective than drugs that are currently out in the market. Now, the drugs that are coming out, based on our own experience, is there's only about a 10% of those that are superior to currently available within the market. The other 10% is maybe inferior, and 80% is maybe about the same. But we do have that 10% where drugs will be better, and that's a positive, and that's a win for everybody involved.
Good outcomes. Quick follow-up question for you. Biosimilars, Dr. Lamb. A lot more? A few more? What's your read on it?
So currently we have 3 approved in the market today. The Zerixio, Inflectra, and the Erelzi. Zerixio, as Dr. Reitz mentioned before, is the only one that's actually out in the market. The other 2 are approved, however, they're pending patent litigations, and we'll probably expect to see them around 2020 or above. But within the pipeline, we are seeing more innovations there where there are more biosimilars that are going to be available within the next 4 or 5 years, and that will really help alleviate some of the specialty trends that we're seeing today. But there are still significant hurdles, that we have to go over with patent litigations, with state-related legislation, and with the whole piece around interchangeability. And so we're closely monitoring, that pipeline, when those drugs are going to be available, and strategizing, how are we going to best manage these new drugs that are coming out into the market.
Okay, thank you for that. As always, our tradition, we end with a series of questions that our audience can be asking their PBMs to help evaluate the effectiveness of their programs in terms of helping to manage the overall increasing cost and spend of pharmacy drugs in the United States and for their clients. And we have 3 questions which we've put together. I'm going to ask Dr. Reitz to go through each one of them and talk a little bit about the question itself and then what it's targeted at determining.
Thanks, Rich. So one of the questions that you really should ask your PBM is, does your specialty drug management program include both traditional and expanded drug management practices, like we talked about, such as the focus on integrated programs? And please provide examples. Well, why is that important? Well, as Dr. Lamb talked about, if you only are utilizing traditional utilization management programs, you're not going to be able to provide the full gamut of care and provide the optimal outcomes for your patients. It not only leads to poor outcomes, but increased costs. So it's really important to assess, do they have something beyond the traditional UM management techniques that they're using with these specialty drugs?
So from Rich's perspective, non-clinician perspective, you've got to have an absolutely outstanding evidence-based medicine process as
foundational.
As well as a specialty drug care management program. You just can't have a good evidence-based management program and a great discount on specialty.
Exactly.
Got it.
So second question, how does your specialty care management program help patients better manage their condition? Again, ask them to provide examples because you really need to see, as Dr. Lamb went over, what are they actually doing? They can talk about that they might have a great specialty program, but if they can't demonstrate some of the best-in-class types of ideas that Dr. Lamb talked about, then you're not going to, again, get the optimal care. If patients aren't engaged in their care, if they don't understand their therapy, again, their adherence will be poor and their outcomes will be poor.
Low engagement, meaning a patient doesn't understand their condition, doesn't understand the therapy, doesn't understand how to take it in a way that's adherent, can lead to poor outcomes, a trip to the ER, an adverse healthcare event, which leads to increased total medical costs.
Exactly. And then again, as Dr. Lamb talked about, you really want to make sure that your specialty program is integrating with the provider community. It's so key that they have that ability to communicate back and forth to one another, to be able to manage the care for that patient so that the pharmacist, the clinical pharmacist, is comfortable with talking with that provider regarding the drug therapy, and the provider is comfortable in talking with the clinical pharmacist about what options there are, and so that they can steer the patient towards the right therapy. So again, ask for examples on every one of these on how they do that.
Yep. So overall, we're looking for an integrated approach with traditional UM plus specialty UM, right? We're looking for specialty programs that drive high engagement, and we're looking for coordination among multiple care providers. Those are three critical components. We've got a few questions actually from the audience today. I've got them right here, so I'm going to post them. Looks like they're both very clinically related. I'm going to post them both to Dr. Reitz and to Dr. Lamb. The first one is, with increased utilization of specialty drugs over the next few years, does that have a direct correlation on decreasing utilization, or let me say this again, does that have an impact on total medical costs?
Great question.
Yeah.
So total medical costs. That's the utopia. That's the vision. That's what we're trying to get to, because as we've been talking about, that's what we want to see. We want to see that we're using medications that impact the disease state, that impact the clinical quality and outcome for the patient, so that we are using less medical costs, less hospitalizations, less ER visits. I don't know, Dr. Lamb, from your experience in specialty, have you seen the medical costs decrease?
I haven't seen it per se right now, but what I think is, if we go back to the example of Duchenne's muscular dystrophy, with really no treatment options prior to this past Tuesday, patients, whenever they had relapse in their disease state, there was really no other way to manage their disease state. So they had to go to the hospital, they had to go see the doctor, and it might have incurred excess medical costs. But because there's therapy available now, that might help control that. And I think those are definitely issues that we are looking at right now to see, well, outcomes-wise, if we look at a drug, does that indeed decrease the overall medical cost for this patient? And as a healthcare continuum as a whole, does the introduction or the utilization of this drug actually decrease overall and total medical costs? I think those are questions that we are definitely trying to answer as well.
Good answers. Question number 2 here. Do you see employers choosing to not cover specialty drugs due to their high costs?
So there are some exclusions that are happening that we're starting to see, and I think the way we've chosen to look at that is that we are really looking to say, are there some preferred agents within the therapeutic class that we would encourage patients to use, or because we preferred them because of improved outcomes with them, reduced side effects, and ultimately reduced costs. And so, yes, some employers are choosing to exclude some of these drugs. We can get into a whole discussion about whether that's a good thing or a bad thing, but I think the important thing goes back to the question above, which is we need to be able to document that by using those medications, you're going to reduce other costs down the line. that's the key. That's the foundational key that we have to build our formulations on, right? Our formularies and ensure that patients are using this right drug.
Yeah, I would agree. I definitely see yes, employers are choosing, and there are a couple of mechanisms to do that. You can do it from a preferred, non-preferred,
right,
or you can do it from just a hard exclusion.
Yeah.
The important component to this, and I think we would advocate for this, is that decision has to be based in absolutely great clinical evidence. It can't be based upon rebate, can't be based upon other market forces, right? It just needs to be based on good science.
Absolutely, absolutely. And again, going back to our evidence-based medicine process, our preferred, non-preferred criteria decisions are totally based on that.
Well, Dr. Reitz, Dr. Lamb, outstanding conversation. Thank you very much both for taking the time to talk with us about specialty. Audience, thank you for the great questions and for hanging with us for a very detailed conversation about the impacts and the personalized approach to specialty care. With that, I will hand it back to Dana.
Thank you, Rich, and thank you, Dr. Lamb and Dr. Reitz as well. Audience, please join our next webinar on November 10th from noon to 1. You can always find the latest information for the RxTalks webinar series at omedarx.com/RxTalks. We will send out a follow-up message to everyone on the call that will include a link to today's presentation and recording. Feel free to complete the survey when you disconnect from the call to let us know what you think about this session. Thank you for attending today and have a great day.